Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today's guest is someone many of you know, or at least know of, and that is Dr. Jeff Rouse. I'm really excited for this conversation because not only is Dr. Rouse a highly respected expert in the field of restorative dentistry and prosthodontics, but he has developed a unique and comprehensive approach to patient care throughout his years in practice. It's an approach that focuses both on improving our patients' dental health as well as their overall health and well-being. And we're going to talk about that in much more detail during today's show. But first, just a bit of background. Dr. Rouse graduated from the University of Texas Health Science Center in San Antonio and went on to complete a 2-year general practice residency at the University of Connecticut. He practiced family dentistry for 12 years before returning to school to receive his specialty certificate in prosthodontics from the University of Texas San Antonio in 2004. Dr. Rouse then practiced with Drs. Gregg Kinzer and Frank Spear in Seattle, Washington, before moving to San Antonio, Texas, to open his own private practice. In 2017, he became a member of the resident faculty at Spear Education in Scottsdale, Arizona, and was an adjunct assistant professor in the Department of Prosthodontics at the University of Texas, San Antonio from 2004 until 2019. He's a member of the American Academy of Restorative Dentistry and the American College of Prosthodontics, as well as a past president of the Southwest Academy of Restorative Dentistry. Dr. Rouse has written numerous journal articles, including a portion of the annual review of selected dental literature published each summer in the Journal of Prosthetic Dentistry. He also published a textbook with Dr. Bill Robbins in 2016 titled Global Diagnosis, A New Vision of Dental Diagnosis and Treatment Planning. Dr. Rouse lectures nationally and internationally on a wide variety of topics ranging from dental aesthetics to airway prosthodontics. So with that very impressive background, I would like to welcome Dr. Jeff Rouse to the Doc Podcast. Welcome to the show, Jeff.
Thank you, sir. Yeah. Appreciate that. I always hate introductions.
I know
they always tell you have to write something down, but I hate hearing it. It's like, for me, a good introduction is private practice prosthodontist in San Antonio, because too many times teachers I don't think actually are in practice. So it's nice to know you actually had to go through and do stuff in practice. But
yeah, I agree.
Anyway,
completely.
I appreciate it.
Well, you earned it. You've done a lot, and I think it actually kind of want to start with that. And if you could take us a little more on that journey, and the background just gives a little bit of highlight to the listeners and viewers of what you've gone through. But I really like to talk about people's journeys. A lot of people know you now and your capacity and how impressive you are and what you are and who you are now in practice. But I find oftentimes people forget we don't all start there. It's a journey and it's a process. And you've had some really interesting parts to your journey, like a 12-year stint in general practice and then back to residency. So kind of take us through from the time you went to your dental school training until you are now, just a kind of a brief synopsis of what that journey's been like.
It's interesting. I'm around dentists every week and I'm brilliant dentists, especially the younger dentists, are just they're getting smarter and smarter.
I agree.
To get into dental school, I think is significantly harder than it was when I was around. And to hear their stories is phenomenal, because actually there's some people that come out and shadow at my office because they have to actually check off, like, I shadowed for 200 hours or something before they can even apply to dental school. I honestly didn't have any clue what a dentist was going to do or did, or I had a buddy that wanted to be an orthodontist, and I was going to medical school. And I realized in my junior year, there was no way my grades or my aptitude or my desire was to go to medical school. So I bailed on that. Had no idea what I wanted to do. And the guy said, "You want to go take the DAT this weekend down in Houston with me?" And I'm like, okay. So as I got in the car, he threw this book over at me. He goes, "You might want to look over that." And so somehow I got in. I don't remember what I made. I must have just killed it because my grades were horrid.
Oh, wow.
And then the guy in dental school, the worst thing that could have ever happened to me was opening introduction in dental school, the guy said C equals DDS. And I was like, I got C's. Like I nailed C's. That was perfect. So that was my dental school. My dental school was, I have no idea what a dentist does. I don't know what I'm going to do. I was clueless as to what would happen. And I met Bill Robbins, who I wrote the textbook later with.
Mm-hmm.
He was a professor my senior year, and he inspired me to actually go to a residency. So you mentioned that I went to a GPR in Connecticut. Um, it was I know what that meant, what it was. I just knew it would buy me 2 more years
Okay.
to actually learn what a dentist would be. At that residency, it was a GPR, but it was run by a maxillofacial prosthodontist.
Yeah.
And it was Connecticut at the back when I was there, which was 88 to 90. Um, Brandemark implants could only be placed by oral surgeons and only be restored by prosthodontists.
Hmm.
And so it was one of the, I think, 4 or 5 surgical centers in the US for Brandemark implants.
I
Because
didn't know that. Wow.
84s, they came into the US in 84. Toronto conference was 84, 85 was when they really started pushing. 88 is when I show up. And so they had to have a prosthodontist on staff because the oral surgeons were putting them in. So I got to spend 2 years essentially doing a pros residency without all the other, I didn't have to do lab work. I didn't have to read literature. I didn't have to do any of that. So I came
Wow.
out with this really great background in how to do pros. And for the first 2 years out after dental school, I worked for a periodontist that all I did was his pros. So he was putting implants in all day long and I did his pros. And then he was in with a bunch of companies. So I designed a bunch of implant systems at that point in time.
Okay.
Um, I say all that because people know me now and don't really know that I did that. You
Yeah.
know, I, um, they asked, in fact, one guy was in a class a few years ago and he said, "Oh, really? You do dentistry?" And I'm like, "Yeah, yeah, I do dentistry."
Yeah. Yeah.
And he said, "Oh, really? What kind?" And I'm like, "Well, I can pretty much do anything you want to do."
Yeah.
So yeah, I have a background in implants. It's pretty deep as far as information and design. And then I went off and decided to purchase a family dental practice.
Okay.
And so now I go into family dentistry and it was a full-on family dental practice.
Mm-hmm.
So we saw starting at 6 months of age is when we first had our first visit.
Wow.
And and so we had a lot of kids. Um, and the guy had gone to Pankey, which is a great place to go to learn really at the time really comprehensive care. So we were doing quadrant gold inlays and onlays. We were doing. He was a very sophisticated dentist for the time,
Mm-hmm.
um, and so he stuck around and taught me how to run a practice and how to do more high end care on patients. I came with the occlusal knowledge from the pros residency, the
Mm.
first pseudo pros residency. So I felt comfortable there. He just really built my knowledge
Mm-hmm.
and how to run a practice. But honestly, the most important thing that happened in those first 14 years was that he was doing ortho in his practice.
Hmm.
He was doing just pediatric ortho. He wouldn't do adult ortho.
Mm-hmm.
And so he said, if you're going to buy the practice, you have to learn how to do it. And so he got me to a couple of courses.
This is like the
Um,
90s now.
yeah, so Bob Garrity ran a course out of Oklahoma as
Okay.
general dentist that um, he ran a long course, an intensive course, and then
Mm-hmm.
he ran a second course, which was 2 years long. So
Okay.
you would go back and show cases and stuff like that. So I was in both of those courses, and then this guy worked with me. So every case I did, I had a guy watching me do everything.
Mm.
Now I mention that because I think there are a lot of pivotal moments in everyone's career, but I think that was an important one for me. It taught me a couple of things. It taught me when to not do ortho. So I think a lot of the fear from orthodontists about general dentists getting involved in ortho, it's going to actually benefit you in the long run
Mm.
because they'll learn what not to do
Yep.
pretty quickly, and they'll learn I don't like doing it.
Yep.
But what comes out of it, which is the second thing, is I absolutely know and think ortho first on all my cases
Mm.
because I know what can be done. So
Yeah.
my mind is ortho first. And I had a partner later whose background was, while a general dentist, was in heavy in perio.
Mm.
He thinks perio first.
Mm-hmm.
And so today it's evolved where ortho is really should be the leader in all of restorative care. And so my mind is just absolutely set for that because I did it for a while.
Yep.
And I know, like, I can see how teeth should move and what's going to happen in certain situations because I did it.
Right. Right.
And so, yeah, and family, that was a huge part of getting me where I am today.
Mm.
14 years into it, I decided to go back to pros, and
Mm.
I actually did that part time. So I ran my practice and did pros
Oh, wow. Okay.
at the
Jeez.
same
That
time.
could not have
And
been easy.
then it was a bad 4 years. Yeah.
Oh my
It
goodness.
was not good.
Wow.
And then I've been practicing since 2004. I've been a prosthodontist. I've been in San Antonio as my main base, but
Mm-hmm.
I also split time in for a few years in Seattle, and that's where we developed a bunch of the airway material that I teach now at Spear.
And how'd you get connected with Spear and Kinzer in their practice?
So I had known them for a while, just sort of socially. I would see them at a meeting and say
Mm-hmm.
hello. I might have said 3 sentences to Frank Spear my entire life, as of 2016,
Mm.
15, 16, something like that. And the other guys out there, Bob Winter's been a friend for a long time. Greg's been an acquaintance for a long time. Gary DeWood, I've known for a long time. Um, those guys always wanted me to come out and introduce the airway concepts because they would come to my
Okay.
lectures and they'd see the lecture and go, "We need this at Spear. We need this at Spear," and
Mm-hmm.
never really happened. And then the people, well, you do it all the time. You lecture and teach and stuff like
Mm-hmm.
that. It's really draining. People don't understand. It seems kind of cool when
True.
you're up there,
Yep.
but you go through in your career as a teacher, that's teaching on the road, you go through a moment where you're scared, and then because you just don't know if you're going to be able to do it,
Mm-hmm.
and you're scared somebody's going to be smarter than you in the audience.
Mm-hmm.
And then you go through this exhilaration phase that's all about you, right? It's like, oh, I'm my ego's getting stroked, which it rarely does at the office because they tend to just beat your staff beats on you,
Yep.
right?
Fair. Yep.
And and then once you go through that excitement, um, most people that do it routinely or become good at it go through a really big burnout phase
Mm.
because it's just so draining.
It is.
And that's where I was. And I was
Mm-hmm.
burned out. And I
Mm-hmm.
finally called Bob Winter and said, can we get serious about me doing something at Spear? And it actually didn't happen, but it put me around Gregg Kinzer, and he
Okay.
needed somebody to come work up in Seattle. So I just went and worked with him for a while. And then eventually the airway, we refined the airway ideas enough that Spear adopted them. And so now it's kind of an integral part at Spear.
That's awesome. So you've actually been a significant part of the contribution to the airway component with Spear through your
Yeah,
interactions with them.
I'm pretty much the airway guy.
Yeah,
No,
that's great.
they'll, I don't know if I like the title, but, but
What
I'm the
was that
airway
like?
guy.
I mean, what was that like when you started with? Because I know what it's like, and we can get to that a little more in a minute on the orthodontic side, being one that's pushing this envelope. What was it like when you were in primarily with general practitioners in that arena, starting to talk more about the airway, so to say?
General practitioners and prosthodontists adopt the ideas very easily in
I've
my,
sensed the same thing.
from what the people I've been around.
Mm-hmm.
I get very little pushback.
Mm-hmm.
And the reason I think that is the case is that we follow our patients long term
Mm.
and we get to see things that are breaking down,
Yep.
breaking or breaking down.
Yep.
And that includes the patient's health
Yep.
and uh, neurocognitive health as well,
Yep.
dementia, Alzheimer's, all the rest. So the idea that poor sleep or poor breathing could create some of the issues that they're seeing in these long-term patients is not a difficult concept for them to understand
Mm-hmm.
or believe.
Because they're seeing it.
Yeah. So so for restorative dentists, I think it's pretty simple for them to accept.
Mm-hmm.
I get a fair amount of pushback from oral facial pain people, and I can understand it um, because the way I teach it is I, and I made this a conscious choice early on, which was I'm gonna believe everything is airway until you prove to me it's not.
Interesting.
So if something sounds like it could be airway, I'm gonna say it's airway.
Mm.
And the oral facial pain people are really smart and they deal with patients that are, neurologic issues, and they've got a lot of different types of patients in their practice.
Yep.
All of them will admit that airway plays a role. I think what their objection in my world, or to me, or to how I speak, is that they don't think it's as high a percentage.
Okay.
So we just argue over percentages,
Okay.
basically.
Yep.
So
Yep.
that's no
Yep.
big deal. I just, we just argue, I would say it's 90% of it. And they go, no, it's more like 60. And I go,
Mm-hmm.
well, okay, your patient base, maybe it's 60, my patient base, maybe it's 90, and in the general population, let's pick a number in the middle somewhere.
Mm-hmm.
And I saw that, I think that's fair, but I do get, that's where the pushback is with them is, and I think it's rightfully so,
Mm-hmm.
that because their practice looks different. Honestly, the biggest pushback, and we had visited about this, I get a ton of pushback from orthodontists. It's crazy. They are the hardest. And I am the biggest advocate of orthodontics. I
Yeah.
think orthodontists are the key to the health of our patients.
I
They're
agree.
absolutely the number one. And I get so much pushback. And I think the only thing I can, well, I don't know. We'll probably talk a lot more about it because there are lots of reasons I think there's pushback. But
Yeah. Go ahead. No, go let go into some of them. What do you, I mean, because I was going to ask you that next. I mean, what are they saying? So what is the pushback and that you hear, and what do they back it up with, if anything, and how
yeah.
do you typically respond?
Okay. So it depends on the patient we're talking about,
Mm.
right? So um, let's take um, let's take like pediatric. Let's 3, 4, 5-year-old kids,
Yep.
right? Or even so. My way of thinking about it is if I see them deviating from normal craniofacial growth and development,
Yep.
whatever the age is, I want to intervene at that point in time because it's setting up a barrier to normal breathing.
Right.
Okay. So I don't care if it's a little barrier or a big barrier, it's more effort for breathing.
Mm-hmm.
And the added effort the patient's going to pay a price for it.
Mm-hmm.
Now, we'll never be able to fully document this much effort equals this much price because
Mm-hmm.
everyone's going to be completely different. Some people
Yep.
can't tolerate anything and other people can tolerate a lot. But the assumption that I'm going to make is that I'm always working with the people that can't tolerate anything. I think that's the better assumption because
Mm-hmm.
that's the way I would want you to treat my child.
Yep.
So if we're talking about early intervention, I, I get tons of pushback from the orthodontist saying that's too early. And the main argument is there isn't a growth spurt occurring, and you want to wait for the 8, 9, 10-year-old growth spurt to happen so that you can take full advantage of the intervention, which makes no sense to me at all. So it, and I ask a handful of questions, which is, am I going to still be working with the same child?
Hmm.
Because neurocognitively, the new research that's out there is going to suggest to you that I'm probably not.
Yeah.
That child will not be as smart. The child will probably have more attention issues, more like just make a list.
Yep.
They're
Yep. And for
going
those who are
and
questioning you on that, I've got reviewed in this show multiple times, but the Karen Bonnick study in 2012 and the David Gozal's had some amazing work on this, talking about that even snoring alone is enough to cause neurocognitive deficits. And the
yep,
Isaiah study in Nature Communications, I believe it was 2021, was a great study that looked across the adolescent brain cognitive development group and took these samples. It was over 10,000 patients and determined that even gasping during sleep can lead to decreases in gray matter and have neurocognitive deficits that ultimately result in poor academic performance, behavioral issues. So this is science, not
yeah,
this is you're not going to open up the orthodontic journal and see this, but if you go digging in from what you're saying, just to give that background in case there's people listening who haven't heard some of
yeah.
those discussions that I've had
Gazal, in
with
fact,
people.
is Gazal, in fact, has said it can cost these kids up to 10 IQ points, which is
Yeah,
huge.
huge. Yeah.
So, um, and it
What do they say
happens
when you say
early.
sorry? When you say something like that to them? Because I know what I hear, but when you have that conversation with them, is that
There's no,
something?
they don't have an answer for it.
Yeah, interesting. Same.
The
That's what I
answer,
experienced too.
the answer always goes back to there's no good science behind it.
Yeah.
So we'll get to that here in a
Hmm.
minute because it's the no good science argument is against the orthodontic intervention.
Hmm.
I also hear, interestingly, not as much today, but I heard for years that the ortho board says not to intervene on kids younger than 7, which I got the what it said, and what it says is that every child should have an orthodontic examination before the age of 7.
Yep. At 7 at the
It,
latest, the AAO. Yes.
yeah.
People, glad you brought
So,
that up because people misrepresent that frequently and say the AAO says wait until 7. The AAO does not say that. I'll
no.
put a link to their website in the show notes for today's show with exactly where you're referencing in the American Association of Orthodontists criteria and sort of outline for general guidelines to parents and the public. And it specifically states what you just said, that it should be at any age at which the problem is detected, no later than 7. So you're
Yep.
110% right.
So if you start looking into the literature on when it can be detected easily, it's 3 and 4 years old.
Mm-hmm. Yep. American Academy of
So
Pediatric Dentistry states exactly that you can detect these issues. Audrey Yoon was on and she said exactly that. And she read me from the AAPD's site that they say the growth disturbances, including those related to airway at a very young age, can be detected and should be addressed. Yeah.
yeah. So I just think they're on the wrong side of history thinking that they shouldn't intervene
Yep.
early. The answer honestly is that they don't feel comfortable treating
Yes.
a 3, 4, 5 year old
Thank you.
because your training isn't on 3, 4, 5 year olds.
No, it's
It
not.
starts at 8, 7, 8, 9, 10, right?
If we're lucky, Jeff. I mean, a lot of these residencies, I talk to residents, not only the residents I teach at NSU where I'm on faculty, but I give lectures for residents around the country. And I'll ask them often, how many of you have treated more than 5? I used to say 10, but I got nobody. More than 5 kids ages 8 or younger ever in all of your dental school or residency training. And this will be residents of all years in the room and maybe get a hand or two that goes up. And most of them did some time in private practice between schooling, or maybe they did a GPR or something of that
Yeah.
nature. Your average student who goes through, as I did, went through 4 years of dental school and right into your 3 year, 2 or 3 year residency in orthodontics. Not only are they not seeing the 3, 4, 5 year olds, they're not seeing the 6, 7, 8, sometimes 9 year olds either. So it's a problem.
So if you never learn to be comfortable with that
Yeah.
age group and how to manage them in your practice, you're not going to want to see them.
Mm-hmm.
And if I stand in front of a group and you're the orthodontist and there are, 100 other, general dentists looking over at you, instead of going, I just don't like seeing them, you typically come up with a reason why you shouldn't see them,
Yes.
right?
Yes.
And so I think it's just a defense mechanism that
Agreed.
people naturally have in that situation.
I agree.
So Interestingly, I've only had a handful of pediatric dentists that have ever attended my courses. And yet when I ask them, what do you think? Are these hard to treat? Should we wait? And they're like, no, these are easy.
Mm-hmm.
4-year-old pediatric dental patient for a pediatric dentist is a piece of cake
Yeah.
because they know how to treat them.
Yeah.
They know how to
Which is
manage them.
which
And
is
their
why
office is set up to manage them.
thank you. Which is why I say all the time, and when my teaching, I have so many more general practitioners and especially pediatric dentists who are pursuing coaching with me in my courses because it for the exact reasons you just gave. They're comfortable with it, they know how to do it, and they can incorporate it into their practice model already. And as an orthodontist, when you have a busy practice and you're going and you're seeing 75 patients a day, it's a cog in that wheel to all of a sudden have a 4-year-old come in, the way you have to talk to them, the way you have to bring the parent back. I mean, a lot of orthos, and I say this because I want people to understand this, and it's not me making disparaging remarks about my orthodontic colleagues. As an orthodontist, I'm extremely proud to be one. It's an amazing profession. I've been very blessed to be one. Part of the reason I'm doing this is I don't want to see my profession suffer and go away by our naivete and ignorance on this. So I'm fighting to raise awareness and trying to call balls and strikes on it. But ultimately, fact remains, when you have a busy practice, you're seeing all those kids, those teenagers, and those adult patients are lined up. You don't want to break free to go deal with a 4-year-old especially if you've never been trained how to incorporate that. So I completely agree with you. It's easier to just say, this doesn't work. There's no place for this. There's no science behind it. And then you can kind of put your head on the pillow at night.
Well, you mentioned Audrey Yoon. She's a pediatric dentist and an orthodontist. So that's, I think, is a huge advantage for her in management. So in that age group, body and brain are growing and developing so rapidly that if we delay, we get damage.
Yes.
So 2 years, the first 2 years of life, brain's developing quicker than at any other point in time. Things can get thrown off very easily. Got to do something about it and got to do something about it as early as possible. If the orthodontist is not comfortable, which mine in San Antonio are not, that's fine. Just say, I'm not comfortable seeing them. They mess up my schedule.
Right.
And I have a pediatric dentist here in town that does ortho for me.
Yep.
It's like, okay, there.
Yep.
So the patient is treated. Nobody gets worked up about it. And a ton of general dentists have learned to do early intervention orthodontics on those kids.
Yep.
Because it's just, they're comfortable in their practice managing them. They've got, they're just good at it.
Yeah.
Because they see them all the time.
Yep.
So, all right. So that's the young. And that's where I really think if an orthodontist wants to see them, I think the tools that you're going to use are the same tools. It's just a management issue at that point in time, but somebody needs to see them and decrease the stressful nature of the breathing at that point, and start thinking through why do I need to expand this kid? And it more than likely is tonsils and adenoids or tongue tie. Those are going to be the two main reasons. Genetics would probably be third on the list, but pretty low on my list. I think tonsils and adenoids, tongue tie. So if you're going to intervene, then you're probably looking at having to do it in concert with an ENT, possibly.
Can I add one more to that, Jeff? I'd say also nasal passageway obstruction from allergies, allergic rhinitis, or chronic infection.
Yeah, it's a good point. Absolutely put it on the list, but I would note that in following this now for a few years, what I've noticed is if you can get the mouth closed and get them breathing through their nose, the allergies, what we call allergies, seem to go away.
Yep, use it or lose it type of effect. Yep.
So you need to evaluate it, but don't rule out that their mouth is open and that's why the nose is shutting down.
Yep.
Would be what I would say.
Yep.
Middle age group on orthodontists as far as not intervening or what seems to be a barrier. Honestly, I don't. That one, what you were saying, the orthodontists are not seeing the 7, 8, 9-year-olds. I don't know. Maybe that's educating the general practitioners in town that we need to see them earlier than what y'all are referring them.
Yeah, what happens with us is because in the residencies, they may see them for screenings, but the Salzman Index, which came out in the 60s, which is how we score these cases for medical necessity, because a lot of schools, a lot of ortho residency programs are located in areas where you have a high percentage of the patients coming who are on state funding, Medicaid, and they're regulated on whether they'll get treatment by whether it'll get covered by the state. So the state is obviously looking to minimize, right, how many people are getting orthodontics.
Sure.
It's kind of low hanging fruit to cut off to say, well, of all the things we've got to cover, straight teeth, right? They're not. That's the crux of the problem that I've got to get to the bottom of, is to get people to look at this, as you've very well laid out, a bigger problem than just straight teeth.
Yeah.
Be that as it may, that's the reality right now. So you might screen a patient at 6, 7, 8 years old, but that's where this whole watchful waiting and recall observation thing comes from, because if that patient has a full unilateral or bilateral posterior crossbite or an anterior crossbite, there's a chance you'll get that covered. Oftentimes you will get that covered. So that's why orthodontists are pretty comfortable with, and of those kids under the age of 9 that they've treated, if you ask, it's almost always a posterior crossbite patient, maybe an anterior crossbite patient, because they qualified on the scale. But in each residency, a resident might get 1 or 2 of those over their initial, course load. The problem is they see a lot of patients who don't have a posterior crossbite. And I always give the example, patient A comes in with mandibular arch width that's normal and deficient maxillary arch width or maxilla, and they have a unilateral, or I used to say bilateral posterior crossbite. So you take the whole shift concept out. The bilateral posterior crossbite, orthodontists go in on that patient 7, 8 years old all day and expand the maxilla. They don't question it. We don't debate it. You take that same patient and you compensate the lower arch in to fit that same maxilla. And the majority of orthodontic residency programs in this country promote that you don't ever go in and expand a patient in the absence of a posterior crossbite, that it's wrong to do, that there's no evidence behind it, even though there's literature on it. And McNamara actually had a great article in 2006 in AJODO on this. So there is literature explaining the benefits of this. I mean, it's not unproven, but that is still the general consensus of the orthodontic establishment, is that you don't do that. In fact, I've applied, I'm open about this, to speak. The AAO has a winter meeting coming up with the AAPD, and I applied to talk about coordination of care between medical and dental colleagues in sensing, understanding pediatric sleep disorder breathing, and creating a team approach to help deal with this, as well as some early interceptive orthodontic strategies to address it. And I was told from them that my topic wasn't interesting or relevant. This isn't the first time they've told me that. And that they were afraid I was going to promote indiscriminate expansion. Well, that's code word for expanding in the absence of a crossbite. So the AAO and the academic establishment, they do not believe that there is any reason to expand that patient B. They'll expand patient A all day. They'll acknowledge the narrow maxilla, but they won't expand patient B who needs expansion. And I've always said, patient B, even though they don't have a posterior crossbite, has a more severe malocclusion because they have 2 arches that you have to contend with. Patient A is just the upper. And I've never heard anybody, I've said that to numerous colleagues who question the approach of going in younger and dealing with this. And like you said, no one ever gives me an answer that can dispute. I mean, it's kind of disputable. It's factual, right? I mean, you can't really debate that, but they do. So yeah, that's a big part of why we don't. When you bring up the question of why we don't get those kids 6, 7, 8, it's the system, because that system, just to finish that out, that Salzman index, they don't count patient B. Even if that patient B has moderate anterior crowding, the laterals are going to be blocked out. They have narrow arch, high vaulted palate. Remember, same maxillary width as patient A with the posterior crossbite. The state will cover you to treat patient A and not patient B. So we are being trained to screen out those patients, and we're taught that we can't treat them.
Well, hopefully we'll get to a point where we can start. There's an ENT study, a couple of ENT studies out of Brazil that are giving us palatal width measurements for health.
Oh, good. Okay.
So we know in an adult, bone to bone, first molar, so palatal bone to palatal bone needs to be 28.5 millimeters or they're going to be sick. So basically we are now saying it needs to be 30. So 30 is our number. And so even if they don't have a crossbite, it's still 30.
Mm-hmm.
and 30 is sick,
Yep.
no matter what it looks like when the teeth occlude with one another.
Mm.
And the other part that's missed every time is that most of the patients that you were saying are narrow but and are compensated are
Mm-hmm.
also Bimax retrusive. So
Mm-hmm.
they almost always need to come forward,
Yeah.
which is the missing piece that, yeah, okay, you know, we can look at two cases and go, okay, that one's easy to see because they're really constricted posteriorly.
Mm-hmm.
But if if they're constricted at all posteriorly, they're more than likely not far enough forward at the same
Mm-hmm.
time. So we call it a class one, and you go, oh, it's not that bad, but it really is.
Yeah.
I mean, Bimax retrusive cases happen all the time. In fact, one today, 25-year-old was in, and um, her teeth, if I gave you photos
Mm-hmm.
of just the dentition, you would go, what are you talking about?
Hmm.
I mean, her teeth interdigitated as well as you can do it
Yep.
orthodontically. It was beautiful. Her teeth are beautiful. And yet they're crammed back in her head too far. I
Mm-hmm.
mean, her airway is microscopic. And so it's exactly the same thing happened to her when she was a teenager going through ortho that's happening to the patient you outlined, which is we didn't pay attention. We only pay attention to tooth-to-tooth contacts
Yeah.
and disocclusion of teeth. We don't pay attention to where they are in the world.
Yeah.
And do they hit norms for, you know, width and AP positioning. And so we've got a woman that if we had gotten involved in her earlier in life, she wouldn't be going through orthodontic surgery right now
Yeah.
to fix the problem. Or, well, I'll go with wouldn't. I bet we're good enough now that we could have avoided some of the symptoms she's having today. Now,
What brought
can't
her in?
guarantee it.
What was the reason? What was her?
Fatigue, adrenal fatigue, and just fatigue in general. 25 years old and just can't, no energy at all.
Hmm.
Reflux, grinding her teeth, kind of the classic.
How did she know to come to see you?
I don't know who referred her actually. I don't know how she came in. I mean, her mom's a patient of the practice, so I bet she just kind of heard
So she
through
knew
her
she didn't
mom.
come. She wasn't looking for restorative
Mm-mm,
treatment. She came
mm-mm.
because she's having these other issues and knows that you
Yeah,
understand
I
this.
heard I heard that
Okay.
you might have an answer for me.
Yeah. Yeah.
And
And you
so
did.
she's all, yeah, yeah. So
Yeah.
she's on board. Brought her dad in today. We're all talked through the whole situation, and everyone. She's like um, as excited for orthodontic surgery as you can be. She's like,
Yeah.
"Oh,
Yeah.
I'm ready. I want to change my life." Right?
Yeah.
She's all in. But
Was it extraction case? Was it
oh, it was not. No, it wasn't. They didn't retract. It was. I think her occlusion. She probably had a class one
mhm.
normal occlusion and just straightened up some teeth. Would be my guess.
Got it. So
But
they
they
by
didn't
waiting
retract her
till
at
she
all.
was an adolescent, she already had these narrow arches, this high vaulted palate. But we see
Yeah.
this a lot. But because she didn't fall into those categories that our profession has told us we need to deal with and need to go at younger and help, we're going to talk about some of your approaches to this and sort of the overall growth process that we want to try to take these patients on. We looked at her for her teeth and we said, oh, and I've made that mistake in my profession, right? Earlier. I mean, I would have taken a patient just like that. I'm not indicting anybody else. And if they came in to see me at 12, 13, before I had this more airway aware mentality, I would have looked at her and, okay, you have room for
Yeah.
the teeth. We can straighten them out and you're good, and wouldn't have even up
That's
that
the
way.
other argument that I do get in this. I would call it if you were going to do 7, 8, 9 year old that you were doing phase one and then phase two ortho. We don't use those terms anymore in my practice, at least. But the orthodontic argument against it was that you always get to the same place. Prophet did a study that said that you can intervene early or you can wait around, and in the end of the day, you get to the same spot. But if you read the study, the marker for the same spot was tooth-to-tooth contact, how the teeth interdigitate. Um, but in fact, they also said in the conclusion of the study, the people that we intervened early on really we didn't think they really needed to even go through ortho.
Mm.
We just did it because it was part of the study format. So
Mm-hmm.
they fixed them earlier. They never looked at what the airway was like, though.
Right. None of
So,
those studies have that say that
so
early treatment's of no benefit. None of them.
yeah. So do they get the teeth to touch each other? Yeah, you do. But I don't care about that at all.
Mm-hmm.
My phase one, what I describe to the people that we're working with is it's not a phase one, phase two, because a lot of parents will go, what, now I have to go through ortho again?
Right. Right.
I have to pay again.
Yeah.
Um, I just talk to the parents and tell them what we're doing now is about the health of your child.
Mm-hmm.
It has nothing to do with their teeth.
Mm-hmm.
So all we're going to do is make your kid healthier right now. Your
Mm-hmm.
kid is having this problem, this problem, this problem. Oh, the other one was the girl said I gag on everything. I can't even take a pill, right? So
Mm-hmm.
just classic types of symptoms. And you say your kid has reflux, your kid gags, they have food aversions, they have
Mm-hmm.
whatever, they wet the bed still, whatever that
Mm-hmm.
happens to be.
Yep.
You make a list of those things and say, this phase of care is not about their smile. It's
Mm-hmm.
not about their bite. It's about trying to get some of these things under control.
Mm-hmm.
And I don't know if it's going to happen.
Yep.
I believe it will, but I don't know. I don't know that for sure, and no
Yep.
one does. I do know if we wait around, there's a chance that they're more damaged down the road.
Mm-hmm.
And I do know if they get more damage down the road, that could lead to a lifetime of problems
Mm-hmm.
that are much more difficult to get rid of once the brain's been damaged by
Yep.
this. So I'm going to make a suggestion that we do whatever it is, expansion, protraction, one arch, two arches, whatever it happens to be.
Mm-hmm.
I'm not doing that. My orthodontist or my pediatric dentist is doing it.
Mm-hmm.
But I make that recommendation that they do it for the health of their child, not for their smile or their bite. And we constantly are reinforcing this is a health step that we're doing at this point. So I think that part also doesn't fit well. And the other thing that I have to fight with is this growth, the idea of growth. Like you don't want to do the expansion until they're actually growing because
Yeah.
you can
Yeah.
then take advantage of the growth. I get
Yeah.
that. But the argument, again, there's two that I have there, which is, am I going to be dealing with the same child if I wait 3 years for a growth spurt?
Right.
To which my answer is no.
Mm-hmm.
And the second is, if you look at any literature that talks about kids with airway issues, and when those airway issues are resolved, they get a growth spurt because they get into deep sleep
Mm-hmm.
and they
Yep.
release human growth hormone.
Yep.
So the argument for me is, I tell you what, if we start getting them to breathe better, we're going to develop our own growth spurt. It's
Yep.
going to happen all by itself. So don't worry about it. We're going to get full advantage of growth.
What about the people who say two things on that? Number one, and this was actually brought up in the AJO DO put out. There was a letter to the editor in May. It was actually on a digital version of the journal in December, and then came up in May in the print publication. And the individual who wrote it is clearly opposed to any sort of involvement of the orthodontist in Airway at all. And make some very disparaging remarks about it, including if our colleagues want to play medical doctor, they should consider going to medical school. So, this is and he actually said in that he was asked to write this paper because of all the early treatment and airway directed treatment going on, which again, I don't know this, but it's in the AJODO. So somebody in that arena, the AAO, AJODO, it's their journal, asked him. He literally says that in the article that he was asked to write a paper to address this issue. So again, the establishment of orthodontia is clearly against this. He wrote it also in response, and he said this in the article, to in 2023, Audrey Yoon, Rebecca Bachau, both have been on the show. We've talked about it, gave some just wonderful presentations at the AAO meeting that year, talking about some of what we're talking about right now. And they were just destroyed for this. And that, that was a lot of blowback on them and on the AAO for even having them there. And so he referenced that because of what was said at that meeting. I mean, he didn't say their names, but you can read between the lines. So the establishment is very much against this. So what would you say to those people who say you or the orthodontists or pediatric dentists that are actually doing the treatment, but the collective you that are focused on this type of treatment are outside of the scope of practice and are treating airway, diagnosing and treating airway? What would be your answer to those skeptics? Be sure to check out the Doc website, where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
The only way we're outside of the scope of practice is if we try to solve the apnea and promise that we're solving the apnea through this.
Yep.
So if you go in and screen for apnea and say, you have this level of apnea, which means that you've violated scope of practice by making a diagnosis.
Yep.
And then you say, I'm going to do this treatment to resolve your apnea.
Mm-hmm.
Then yeah, I could see that argument being appropriate. I liked screening tools. I like a lot of screening tools because I like to know a baseline. I like to know if everything is okay or is okay or not. I very rarely use them anymore. So it's once in a blue moon that I would use them. If I do use a device, it's called a cardiopulmonary coupling unit, which is just looking for sympathetic activity. So all I'm saying is you're sympathetically active all night long, and we need to calm that down. It's a heart rate variability monitor, in other words. Okay. So to go and set up a practice based on I'm going to fix your apnea as if I'm a sleep physician, that's not my model. That's the argument against people making sleep appliances. And it's not what people that are doing this are telling people. They're saying you have symptoms associated with poor breathing.
Yes. Thank you.
And these symptoms, we know, I said wetting the bed, sweating at night,
ADHD,
sleep
sure.
talking, all those things have absolute scientific literature that says that poor breathing can be related to those things.
Yes.
We also know that avas, tonsils and adenoids, tongue tie, we've talked about that. But a huge part of not being able to breathe well is anatomy.
Yes.
Huge. In fact, number one.
Yeah.
Right. So if there's anatomy that is restricting your ability to nasal breathe, then you're going to not be as healthy. And so your symptoms are going to be worse.
Yep.
So I'm just asking, I'm looking at a set of symptoms and I'm saying these don't look good, which is what an ENT does nowadays.
Yep.
They base surgical decisions on signs and symptoms.
Yep. Correct.
We look at it.
Yep.
The ENT goes, yes, tonsils need to be removed, adenoids need to be removed because of these. We look at it and go, these signs and symptoms say we ought to be doing something to actually assist you in closing your mouth and breathing through your nose.
Right.
So we're not dealing with treating apnea. We're treating the signs and symptoms associated with it, and then looking at what could be the culprit. The culprit is the anatomy.
Right.
The other thing that I would say is I really feel sorry for the patients of and the family of the orthodontists that are belligerent enough to be blinded by whatever reason.
Yeah.
Because it's their patients that are actually going to be suffering because of it. To sit around and say, I'm not treating, even though my daughter has all these symptoms and she's constricted and all the, she's the patient you described earlier.
Yeah.
Where she's lingual verted on the lower, but her upper teeth are in a decent place and she's got ADHD and she wets the bed and she has all these symptoms. But that dentist would essentially say, I'm not willing to treat her because I don't have full scientific support behind the actual treatment. And I feel sorry for the patients. And I really feel sorry for the fact that and we did have a discussion about this, which is when they challenge literature, like some of the things that Audrey and Becca have produced. I mean, Audrey Yoon has produced some wonderful scientific literature
Mhm.
to justify the treatments that we're doing.
Yep.
Mariana Evans, lots of people are producing literature. And what I hear all the time from the naysayers is the fact that the literature isn't quality. The literature doesn't reach this standard. And what I would remind them of is that we're supposed to be using best available evidence.
Mhm.
So show me a piece of literature that's better than that, saying the opposite. And when you go
Thank
back
you.
into the dental school training that they went through and look at the literature associated with the decisions they're making, that literature is horrendous. It's
Horrendous.
horrible.
Yep.
So it got in their head that that was gospel, but they never went back and reflected on what it really said. And if
Yep.
they reread it, if they'll take the time to reread it, they'll realize that it is significantly weaker than what is being put out right now. So best available evidence says that you ought to be treating these kids.
Yep. Yeah. And that is such a great point. It's so funny how many things we have in common and feel similarly on. I guess both fighting this fight and just kind of coalescing our ideas. You start to realize that a lot of what they say, the naysayers, is really based on nothing. And I've said to many people who question this, I said, one thing I'll add, I agree with you. I feel very sorry for their patients. I actually will add, I feel sorry for those providers because the rewarding feeling when you actually
Oh,
do
yeah.
uncover this on a patient and you change these kids' lives. I mean, honestly, Jeff, there's nothing like it. I mean, you've done some obviously amazing restorative work in your career. I've done some amazing orthodontic work in my career. It's all well and good, and I'm proud of it, and I enjoy that. There's something different when you detect these issues on a little one and they come back and they're a different kid, and the parent is like, oh my God, you've changed her life, his life, our life as a family. Like everything is
Yeah.
better. All these concerns we had about our child, and they were starting to be falling back in their schooling and getting special help and tutoring and all these things that were going on. And because you got us the detected this and got us the ENT and or allergist, or we started the orthodontic treatment or whatever it is, right? We have a different kid on our hands. I really do feel sorry for the gentleman who wrote that article that he'll never get to experience that because
Yeah, I agree.
it's such a cool feeling. And the other thing is yes, the literature. I've said oftentimes, well, that door swings both ways. You have to prove that what we're doing doesn't work too, right? I mean, you can say all day long that oh, there's no proof it does. Which again, I can go through the literature. There's lots of cases, especially from the medical literature, where normalizing the anatomy, et cetera, does help. Audrey's had some great work on it with her Stanford team. As that is one aspect of it. The other aspect is like you just alluded to. Show me where it doesn't work. Show me where your way works better. Show me the double blinded study. Show me the randomized control trial where we treat your way and my way and you come out better in the end. They say, oh, well, the onus of the responsibility is on the one doing the treatment. Well, neglect is also has a responsibility. If you're neglecting to treat a patient, you should have some evidence that the neglect that
Yeah.
you're prescribing, right? The
Well, so
watchful waiting.
you mentioned watchful waiting, and if you
Yeah.
notice that the studies on watchful waiting now, having watchfully waited, are all coming back saying that wasn't the appropriate way of doing it, that
Yep.
those kids suffer more than the ones that you intervene for
Yep.
whatever style of intervention, especially if the kid doesn't all of a sudden revert into nasal breathing. They're going to be more harmed.
Yep.
So I waiting is not an option in my opinion. I think
Yeah.
we need to intervene. I'll give you the end of the story, or a story,
Mm,
related to that is the last few weeks I've been out, taking care of somebody that went through orthodontic surgery.
mm.
And, if you look at her photos from childhood, you could see it developing. She was interestingly offered, or the parents said, this is probably going to be orthodontic surgery. So even back when she was growing up, they knew that she was going that way.
Okay.
Um, she has smiles attractive, ladies attractive, but all the medical issues, breathing issues. Her mom is 75, looks exactly like her, died of a stroke last year.
Oh,
And she said, I don't want that to happen for me.
Mm-hmm.
because I see myself going that way. And so she went to orthodontic surgery. Well, she doesn't want her kids to end up that way. And she's got a 9-year-old daughter that looks exactly like her.
Mm-hmm.
And they went, so she got early expansion done, but they did get her to close her mouth, didn't get the tongue in the roof of her mouth.
This is
And
the
so
daughter
she's
that had it.
collapsed. Yeah, the daughter.
Okay.
So she's collapsing again. So at 9.5, she's collapsing. And the orthodontic visit, the next visit is scheduled for next September. So a year from now.
Mm.
And so she called up the orthodontist and said, she's collapsing. They just went on a road trip. She's starting to snore. She's starting to mouth breathe. When she sleeps in the back of the car, her mouth's open. She sleeps with my son. She's snoring all the time. That's not good. And the answer was, well, we'll see her in a year. We'll see how she's doing. Worst case is she'll get an orthodontic surgery like you. Like,
That's the answer from the orthodontist.
yeah.
Mm.
So it doesn't make sense. It to say in the example you just gave, there's no literature to support me intervening at this point in time. I need to wait a little bit longer until I hit a growth spurt, or I need to do this or do that. Are you really willing to just let them grow with that and then
Right.
say, well, the out is that we can always do orthodontic surgery?
Because I think,
I,
like you said
I
before,
don't know.
Jeff, because they know how to do that, right? I mean, that part they've been taught, right? You set up the case for an MMA as an adult, you can handle that. I think they don't even know,
Well,
sadly, I
they
mean, where to
need to
begin.
take care of someone they need to be with somebody for post surgery
Right.
and actually sit with them and watch what you have to go through to make that happen.
Yeah.
Now, I this lady's going to be everything's going to be wonderful for her, but wouldn't it have been cooler to have done it at 7, 8, 9
Right. And if we know we have
and
to
done
normalize that anatomy at some point,
or 3?
don't we want to normalize that anatomy when they're young and pliable, or as
Yeah.
Marianne Evans says, juicy? They're like, why would we wait until they're at peak rigidity and
Yeah.
maximal structural resistance and obstruction to try to go through some very invasive procedure, which I don't know many orthodontists out there who deny that a maxillomandibular advancement, an MMA surgery, is going to be kind of the gold standard surgically for addressing sleep apnea and sleep disordered breathing in adult patients. It doesn't seem like a big stretch to me to say, okay, if we can agree on that, then can we agree if we can do it younger and prevent that, that we're doing a
Be a
good
good
thing for
idea.
the patient?
Yeah.
And I've never had a good answer to that.
Yeah. I don't know. It baffles me that I can't get the orthodontics more on board. I mean, I'm not. I mean, obviously you do, and there are lots. Um, but I mean, I always tell a story about a guy that's a friend of mine. He was a restorative dentist for years, went back to ortho, and and when he was a restorative dentist, I talked to him about Airway. When he was actually went to school down your way. When he was in residency, I actually went down and talked to the residents while he was there. He invited me in, talked about Airway then, talked about Airway when he was already an orthodontist. He saw me at a meeting after that. And then finally, Becca Bachhaus, he called him, Becca, and said, you know, Jeff's bugging me about Airway again, and he doesn't know what he's talking about. And she goes, "No, you need to listen."
Mm-hmm.
And once he listened and started seeing it, then yeah, he's all in at that point in time. But it took an orthodontist telling him,
So,
not a restorative dentist. So
yeah.
I guess the last part about, why is there pushback is because I'm a prosthodontist and not an orthodontist. And so I'm not the expert. And maybe it requires more people like yourself to actually make the change. And we're getting them, but
Mm-hmm.
we're not getting them we're not getting as many high-end lecturing orthodontists as I'd like to see.
Mm-hmm.
I think there's a space for people to do that, and it just requires you to slow down, photograph and document your cases better.
Mm-hmm.
Um, be willing to put the time into learning to lecture and actually providing those lectures. But I think the more people that we get involved, the quicker this is going to turn around.
And you said there about they don't listen to you, and I agree. Sadly, I don't agree with why, but I agree with your synopsis of it because you're a prosthodontist. Because sometimes that ego can get in the way of my colleagues and say, hey, look, we're the orthodontists here. Um, that being said, I actually look at it 180 degrees the opposite. I look at it as I had some experience in general dentistry during my residency. Did moonlighting for that. I have family of general dentists. Um, I would look critically at my adult patients that came in that had previous ortho, and in that little bit of exposure to orthodontic results 20 years out, let's use 20 as an average number, I could tell something happened in their orthodontic treatment that wasn't ideal, right? I'm not talking about your relapse if there's some sizers crowd a little bit as a bite sort of deepens a little bit, or there's little things that are going to shift over time, obviously. I'm talking about the patients that came in, and I want to hear your thought on this too, but just from what I saw, I would see some patients when I was doing the restorative dentistry part-time with had 4 biexos, their end-on class 2, retrusive lower jaw, if not maxilla as well, deep bite, obtuse interincisal angle, sawed off premolar and canine cusps, all sorts of attrition on the anterior teeth, periodontal involvement, sometimes mobility anteriorly. Jeff, I saw it all the time. And here I am learning in my go back to, put my resident hat on when I was at UConn, and I'd go back and I'm doing this to patients in the clinic being told this is the right way to treat. And I'm like, I just saw a patient the other day where we weren't allowed to moonlight at UConn, so I didn't say anything about that. But which is also sad because it just was an amazing opportunity to learn. I learned so much. I don't think I could have ever walked out of my residency and opened my own practice from scratch had I not had that experience, because it just gave me confidence and opened my eyes to being on my own and sort of cutting that cord. But it also helped me see a little bit of, because that the town that I ended up going back to practice in, which is where my family's general dental practice was, where I was doing this, the orthodontists in that area were for many, many years very heavy extraction, right? That's just what it was. They just were super heavy on the extraction side of things. And so I would look at these patients and narrow arches, no space for their tongue, just broken down dentition. So I feel that the restorative dentist, especially a prosthodontist with your level of experience, has much more clout in this discussion, because orthodontists don't look at their patients 20 years later. You guys do.
Yeah. Yeah. I don't think we ever get together and talk about it in that way, though.
I agree.
Right. I
Yeah.
don't think we talk about if I need to retreat for some reason, then we have those conversations.
Yep.
But I don't think we actually, it'd be a good idea at the study club just to take a bunch of pictures of what we see in here are people that went through ortho when they were younger. Let's look at what they look like now.
Yeah. I think we should do
I
it.
think that would be education, a good educational experience.
What did you see?
You know,
what are some of the
well,
things, if you wouldn't mind elaborating on?
let me just speak to the 4 by stuff.
Yeah.
Because I probably misspoke earlier when I said that, um, or no, I wasn't as clear. The that we're focused too much on how the teeth interdigitate with one another.
Okay.
Um, I needed to add a little bit. We're focused on how the teeth interdigitate with one another within the current housing of bone. So, orthodontist, my impression for years and what you're describing is patient comes in with crowding.
Mm-hmm.
They have a given housing of bone that they're working with. And they say, how do I get the teeth within that housing of bone?
Mm-hmm.
And get all the principles of occlusion met. So aesthetics and function are met,
Yep.
but within the housing of bone
Yep.
that we're being given.
Yep.
And the answer is, if you don't think in terms of making the housing of bone larger, the answer has to be slenderize the teeth or take some teeth
Right.
out.
Remove tooth
Right.
rolls. Right. Right.
And so it makes logic, it makes sense. It makes perfect sense why that's been the philosophy forever and ever.
Mm-hmm.
So I'm not changing the housing of bone. I only have one choice in this particular case, and we're gonna figure out how to create space that way. So the question that always is given to me, because you're describing the fact that that patient has an airway issue down the road,
Mm-hmm.
right? They're constricted, they're grinding,
Mm-hmm.
they probably have reflux. They've
Mm-hmm.
got all these other symptoms associated with neck pain, back pain,
Mm-hmm.
morning headaches, all the rest, right?
Yep.
So and we call, as a restorative dentist, we always call those my TMD patients.
Yeah.
My
Right.
TMD
Right.
patients
Right.
always would be the muscle pain, headache, and I would go, they took out 4 buys, and
Mm-hmm.
that's the reason. But I thought it was because of how the occlusion set up, right? And
Okay.
or how the teeth weren't in harmony with the joint, or
Okay.
how the anterior envelope was being constricted,
Sure. Okay.
right?
Yep.
So the
Yep.
patient had to function back too
Right.
far and push
Right.
themselves off the disc.
Yep.
You and I were both looking at mechanical things, right?
Yep.
I was looking for a mechanical answer. The orthodontist is looking for a mechanical way of getting the teeth within the housing of bone.
Yep.
And we both missed the biologic component, which was you need to be able to breathe. You need to be able to create space. You need
Yeah.
more room for everything to fit in place. So the AJO's statement on sleep apnea, and
Yeah.
as it relates to 4 by extraction, is true and false.
Mm-hmm.
It was written the statement is true. Taking out 4 bicuspids is not going to create apnea.
Right.
The fact that you have to take out 4 bicuspids is what's going to cause the apnea.
Yes.
And I add to that though the false part, which is it implies that there's nothing you could have done about it. It
Right.
was just that was just it.
Right.
When in fact, taking out the teeth, it never makes the airway better.
Right.
It either keeps it the same or it worsens it over time. And there are certain people that are more prone to the worsening than others. And there's studies that have been done over in
Mm-hmm.
Asian populations to show that in
Mm-hmm.
particular, they're just more, they get more damaged easier from a little loss of volume. Um, so the mindset has to change in orthodontics that this isn't about a smile and it isn't about bite.
Yep.
It's about maximizing normalizing the anatomy.
Yes.
So don't accept what you've got. Know that you have tools to change what you've got.
Yep.
And I would point, there was an article written in 2011 in a journal that I'm not going to be able to come up with the name of right now. But the study was looking at heart rate variability, which I said is a marker for overall health.
Mm-hmm.
A lot of people with Oura rings and Fitbits are using heart rate variability now as a marker.
Yep.
And the study says that if you compare class 1 patients, and remember, you and I said earlier that class 1 molar doesn't mean you're healthy
Mm-hmm.
and that everything's in the right place.
Yep.
They assumed that to be the case, but I'm finding tons of class 1s are actually Bimax retrusive,
Mm-hmm.
which means the results of the study are even better than what I'm going to tell you, because there are a bunch of sick people in the class 1 group.
Yep.
Okay. Because
Yep.
that's my control, class
Yep.
1. They then got class 2, div 2, class 2, div 1, class 3 patients. And they did heart rate variability monitoring on all those patients. And all of the patients with malocclusion have low heart rate variability, meaning they're sick
Mm.
in comparison to class 1 patients.
Mm.
And knowing that some of the class 1s are actually sick
Right.
and we put
Right.
those in their own little group,
Right.
it really even becomes more special
Yeah.
how important anatomy is to the overall health of the patient.
Yeah.
So the idea that we're going to wait around, or the idea that we're going to take out teeth and not try to normalize and expand, or that we're going to just wait and see, maybe we'll get orthodontic surgery in the future, you're just, you know, for someone to say, well, you're working outside of your scope and you're practicing medicine and stuff, I wish that person would actually start practicing some dentistry that led to better medical solutions down the road because their patients would really prosper from that.
Yeah, yeah. I feel they're taking the easy way out. They're just pointing fingers. They're not doing anything to solve
Yeah.
it. They're not doing anything to do the research that they're calling for. They're just content with staying on the course they're on, putting their head in the sand, and pointing their finger while they're doing it at anybody who doesn't
And
agree with.
completing a bunch of dentistry, and that's leaving their patients ill.
Yeah, and another big fault, which you referenced with the AO white paper in 2019, and I completely agree, and won't go into too much detail on it, but I say all the time with the extraction, like I say to the residents, like there's this whole thing of extracting teeth doesn't cause an airway problem. I'm not saying that, like, if you just take someone without an airway problem and just remove 4 premolars from their mouth, it's not like boom, you snap your fingers and they have sleep apnea, right? It's not that's what they've kind of conflated it to become, and made this sort of assumption, or I feel like it's almost done intentionally to do that, to try to save the cake, because you can't prove that, of course not. But what you said is so true, and that is, it's not just about the physical removal of tooth mass. That's a sign, if there wasn't enough room for the teeth, that they didn't have normal anatomy, and that if they were young, that's an opportunity to grow them. I mean, McNamara had a study in '83 on this with Howe and O'Connor, and they measured. There was 104 casts, but they had 54 casts with severe crowding, 50 without, and they measured the tooth width, and they concluded, it was an AJO in 1983, that the difference was not of tooth size. The tooth sizes were essentially the same. It was a jaw size problem, and recommended that the profession take an approach which is more aggressive in the normalizing growth, rather in younger patients, than going in and removing tooth mass. I mean, that was their conclusion. Again, we pull literature that's so convenient. The people who post this pull literature that's so convenient. The Larson study that they love to quote from 2015, which is just garbage on every
Horrible.
level, and
Yeah.
it's horrible. And I mean, it's the retrospective cohorts. It's terrible, and there's on scope today to go into that, but it's not at all anything that they should be proud of, and doesn't prove anything as far as the end outcome. So there's a lot on both sides, and there's a lot of finger pointing going on. But the one thing that those of us who feel the way you and I do, and our colleagues who agree with us, is we're changing lives, and we're helping people thrive and do better in life, in every aspect, not just have a class 1 occlusion or whatever our goals are, right? Or a nice smile or whatever it
Yeah.
might be for the teeth. We're taking it to a completely different level. And to me, that seems to be where we should be trying to go with all of this,
Yeah.
right? I mean, isn't that the goal? Isn't that what we want to do?
Oh, totally. When I talk to restorative dentists now, which would be basically the third set of patients, we talked about really young and kind of the regular ortho patient, then the adult patient.
Mm-hmm.
When I talk to my restorative colleagues now, the change that we're promoting there, or, well, let me back up. We used to really base things on screenings, as I said. So we were focused on how sick are you and what can we do? And we worked with medical colleagues, but it's really frustrating to work with medicine because they can't do anything,
Mm-hmm.
right? They have to jump through hoops, they have to go through insurance. They really don't get a lot done.
Yep.
Um, you and I just decide, we go back to the office and decide to change, we can change pretty readily.
Yep.
And so medicine is hard to work with, hard to get paid for. And being confined by that limits our ability to treat our patients more effectively,
Yep.
in my opinion.
Well said.
So if you think, and I said it earlier, that if you make a beautiful smile, so big, broad, natural smile,
Mm-hmm.
and you get the bite right, which means we got the mandible in the right location. Once again, lower arch expanded out, so we're not compensating or
Mm-hmm.
camouflaging at all. So we've got broad lower arch, forward in position, big maxilla that's in, once again, forward and wide and
Mm-hmm.
everything. So you get a beautiful smile and beautiful function with a patient that's going to be healthy.
Mm-hmm.
Now, how healthy? No idea.
Right.
but they're going to be healthier because I've yet to see a study that said we can intervene to accomplish what I just said as far as structurally changing a person from
Mm-hmm.
constriction to normalcy, and they get worse.
Right.
I've never
Good
seen
point.
that.
Me neither.
So they always improve a little or a lot, and that's exactly what I tell my patient. At the end of the day, you're going to be healthier. A little or a lot, I have no idea because I don't know how damaged you are.
Yeah,
You
and
see,
that's
your
the
whole
measurement.
life you're getting damaged. And I just don't know how damaged. I don't know how damaged, and I don't know how your body's going to adapt to this new change that we're instituting. Will it heal itself or not?
Yep.
I don't know. But what if it just does a little bit? That's a little bit better than what you would have been otherwise. And you're not going to continue to get worse 10 years and 10 pounds down the road because we've set you up better. All right. So we're better for the long run. We may not be, resolving all your issues, but we're a little better. We're going to be better than you would have been had you been living that way year after year after year. And you got a great smile and a great bite,
Right.
which is what I mean, I've always wanted to do that.
Right.
I just now know that I can add this health component to it.
Yep.
By adding the health component to it, now I get people's interest because it's very hard to sell ugly and it's also extremely difficult to sell function.
Mm.
Like your teeth will bite better, your
Mm-hmm.
jaw will feel better,
Mm-hmm.
whatever. Or your smile's ugly and what I mean, you did restorative dentistry for a little bit, so people come in with ugly crowns. I mean, that's hard to talk to people
Mm-hmm.
about.
Yep.
But if you say, I could, these things I'm seeing in your medical history and the fact that you have reflux on your teeth and you're grinding your teeth and all that, I might be able to make that better.
Mm-hmm.
I might be able to. In fact, it's going to be better. I just don't know how much better.
Mm-hmm.
Would you be interested in that? Because in the end, you're going to have this great smile, great bite, and we can replace these crowns and we can take care of the wear on these teeth. So you get to do a ton of restorative dentistry as well. So for the restorative dentist, it's a win because we've never been able to really find a talking point that allowed us to do the dentistry we've wanted to do forever.
Mm.
The difficulty for restorative dentists is not having the conversation, and it's not so much putting together the treatment plan. Today, one of the biggest challenges is finding orthodontists willing to do the intervention strategies that they need done because we need orthodontists that are willing to be more contemporary in their thought process,
Yeah.
custom MARPE, SFOT,
Mm-hmm.
orthognathic, um, and include those in TADs, plates, all
Mm-hmm.
kinds of things. So if you're going to play this game of normalizing anatomy, you have to practice at a level that's different.
Yeah.
And we talked about how hard it is to treat a 3-year-old or a 4-year-old in the middle of a busy 75 pack, patient day. Adults pose the same challenge,
Mm-hmm.
especially when they're not just taking care of some crowding on lower
Right.
anterior
Right.
teeth.
Changing aligners. Right. Just simple, basic stuff. And you said a couple things that I just want to touch on. One is the time in the diagnostics. That part of it that you were alluding to. That's another problem in the orthodontic profession. We've jumped over the the diagnostic process. And I'm constantly talking to residents about that they can't do that. What separates us is our ability to diagnose and detect these problems. And so in the effort to just keep those patients coming and going, that's another challenge that the profession faces is most orthodontists that are busy don't want to spend a lot of time in
Yeah.
this diagnostic process. They want to
Yeah.
look at an image real quick. That's why a lot of them don't even want 3D because they don't have the time in their day to look, got to look through an image a little more detail. You got to be a little more thorough.
Yep.
You can't just hold up a pan, hold up a Ceph and be like, yep, great. And look at some pictures and say, we're going to do this and tell your TC, tell them, braces, 20 months, whatever the case might be. I mean, that's what happens in most orthodontic practices. When I started changing my approach and doing this, I had to take more time to learn myself, train my team, build different systems, change my doctor time scheduling. I mean, so there's a lot of things that the orthodontist is just much more, again, convenient to say, doesn't work, not interested. And that's not even on the clinic. This is in the back end side. This is in the, in the records room side and in the consultation room side. This isn't even the front facing clinic side, which we also talked a little bit about the delivery of this care. The other thing is what we're measuring. And the AAO, so many of these people that say that article I referenced, that letter to the editor, all they talk about is OSA. So when people hear you make the comment that there's not studies that say that it doesn't make an improvement, I guarantee there are people who are going to say, oh, there are studies that say that even if you expand, it does not change their AHI. That's what
I care about.
Exactly. Like that's such a misrepresentation, and it's a fool's errand. Why are we
AHI
focused?
is not a AHI as a marker for health will go away in the next few years.
I completely agree. And especially in the pediatric population, where it was never intended to be used like it is as this all or nothing barometer of whether or not these kids, and I've talked about a lot on this show of why that's such an inaccurate measuring tool for children, especially. So I'd like to hear your thoughts
it'll
on
be
that.
it'll be quality of life types of measurements.
Yeah.
Did you resolve the symptoms will
Yep.
be how it comes through.
Yeah.
The first part was, how to, in the ortho practice. We've had this, I have a couple different study clubs and that I help with. And so I've gotten to have that exact discussion about how it works within an orthodontic office.
Yeah.
The other thing is you have to charge more for this kind of care.
Yeah.
And so there's this pressure of, well, the guy down the street charges less type of thing that you have to deal with. The take home from a lot of different meetings with orthodontists and study clubs for us is that your job would be it. Well, let me back up. In an ideal world, the patient is referred from a restorative dentist to you, with the restorative dentist making the diagnosis and a proposed treatment plan. This is what I think we ought to do, so that you get a patient that's already heard what the problem is, already heard a proposal of possible solutions, and you refine that plan into a workable orthodontic plan, because most general dentists will not be making a referral with a cone beam, right? It'll be a visual examination and then the cone beam, and I don't make cone beams at my first visits. I make visual examinations through photography and an intraoral extraoral examination, and I make assumptions of what I'm going to see on the cone beam. Okay, so I put together an outline. This is the problem. Here's who the patient is. Here's her problems. Here's a proposal that I've run by her, and she's interested in pursuing that. Then you get that, and all your time is spent on, you don't have to come up with the problem. You just have to go, okay, will this proposed solution work, or do I need to go a different direction, or do I have a better idea?
Yeah.
Okay. And that's the best way for it to work, because now it flows in your normal cycle of the day, right?
Yeah.
When it doesn't work is either I made the referral by just checking a box, please evaluate,
Yep.
which is too common and unfortunate, which means that my colleagues have failed, or the patient is the mom of the 10-year-old you just finished treating and said, hey, I've always been interested in whatever, right? In which case you're taking the lead. So if the restorative dentist checks the box, I don't have a good answer for that one. I have an answer, but not a great one. The other one, though, that comes to you, I'm going to urge orthodontists to actually create an awareness of what they see and then refer the patient to a restorative dentist, and let the restorative dentist play a bigger role in the development of the diagnosis and creation of the plan.
Yeah.
Because most of the time when it happens, the cases you're thinking about and describing to me, there were you described, they have wear on teeth and they have, right?
Hmm.
Well, those are going to require restorative care at the end.
Right.
And typically, pre or interim orthodontic bonding is the way that we handle it
Yep.
so that you have a better way of completing the case,
Yep.
right? So there's set up the interdisciplinary team by you, instead of you going through and trying to figure everything out, stop
Yeah.
and just say, this is what I'm seeing. These are problems. I think we need to involve a teammate in this.
Hmm.
Just the way that I do it, these are your problems.
Yep.
Here's what I'm seeing. I think we need a teammate. And I send them to you. You send it to us.
Yeah.
Now I can I don't see 75 patients a day.
Right.
I can spend significantly more time with the patient formulating a plan after you and I have talked. And now when they come back to you, they're ready to just be a regular orthodontic patient at that point in time.
Yeah.
The
And
one that's sent by me to you, I think what would be a good way of doing it is exactly the same way. That's my suggestion. Um, to start educating the dentist. Hey, instead of checking a box, how about we do it this way?
hmm
And turn them into the good referring patient, doctor.
yeah. And it's as you're saying that, I'm thinking maybe that's part of the solution with the pediatric patients as well. Since the pediatric dentists seem to be, and even the general dentists who are seeing these kids younger, right? Maybe we could get them to have the same sort of screening techniques and acumen in looking at these issues young, seeing these airway issues. And I know a lot are, and there's probably people listening thinking, Mike, I'm doing that already. I know we've got to get the orthodontist to be able to be accepting of this. That's the other side of that coin. But the first side is if the general practitioner in the pediatric population as well, or the pediatric dentist recognizes these things, does that initial workup of the airway and of the overall problem with the growth and development and the need to normalize anatomy, right? Not just about straight teeth. Many times in private practice, patients would come in to see me because they knew what I did and they knew what I was doing with kids younger to help them grow. And they would say to me, the general dentist, the pediatric dentist, they said I'm crazy to come now, or I don't need to come yet, or it's too soon to come to see you. And this would be a 6, 7-year-old kid sometimes. So
Yeah.
I'm tough on my ortho colleagues, but I think we also need to look at, like you said, there needs to be on both sides that they help
Mhm.
check this sooner, educate those parents and patients. And that's such a great way to think of it. I hadn't thought of, because if they're coming into the orthodontic office already prepared for this, then when the orthodontist tells let's not even go the 3 to 5 yet, let's just go the 6 to 8, that a lot of orthodontists are still hesitant to do any of this on. Now they kind of hit the ground running, right? They've got a little, just like the restorative case you mentioned, there's already a background with mom and or dad and the patient. They kind of know, like, yeah, we know that it's not about the teeth as much at this age, but Dr. Smith, our pediatric dentist, said that she's worried about how she's breathing and she's got these sleep related issues and these behavioral issues, and that she thinks it may be because of the width of her
Yes.
jaws or lack of tongue space. And if they came into their office like that, I had one practice in particular I worked with, a pediatric dentist that got it. They got it. And they would send their patients to me scripted on, they understood it. They would say, our pediatric dentist said, this is what's maybe
Yep.
going on. Boy, that was a much easier. I didn't even think of it until you just mentioned it. But I contrast that with the patient that comes that the pediatric dentist kind of said, you don't need to go. And the parents persisted. That was a much different consultation for me and for
Yeah.
my TC, much
Yeah.
different to try to educate them and spend all that time. So that's a really
Yeah.
interesting point.
If I was getting out as a young orthodontist, I would, I mean, that would be where I'd spend a bunch of time. Is I would spend my time showing them the signs and symptoms associated with it, signs, symptoms of sleep disturbed breathing issues, and what normal anatomy should look like and what variations of normal look like,
Yep.
so that they get a very clear vision. And then I would tell them how to make a referral. And I don't think people, I've never heard an orthodontist in a study club setting explain how to make a referral. They're shy for some reason about that. They're just saying, refer them to me. Here's my pad. Just
Mm.
check a box, call my office, whatever it is. How to make a referral is something that restorative dentists are not taught to do very well.
Mm.
Um, and so they just go, I think you need to go see the orthodontist. It needs to be more in depth than that. And so an explanation of how would serve your practice well. But remember, the other needs to be true, which is you need to, especially instead of being the 5, 6, 7 year old, if it's the 45 with wear and pain
Hmm.
that's seeing you because they don't like the aesthetics of their teeth and the crowding that they're getting on the lower teeth,
Hmm.
you, I don't think orthodontist, I've never like mid-course gotten somebody sent back to me to say, hey, can you do the initial stuff on this? Because they don't need to be with you yet.
Hmm.
They need to be with me because this is bigger than
Yep.
that. Um, so that would be, and your challenge is going to be if they happen to have a dentist where you don't have complete control of who you want to send it to,
Yep.
right? So,
That is a challenge.
um, and then, but y'all manage that all the time. I know
Hmm.
my orthodontists, they, I get a lot of referrals, especially one of them is better than the other two, and he's just willing to sit down and say, hey, this one's kind of a tough one. Here's the
Yep.
challenges we're going to face. Is that something you want to do, or should we send that over to Jeff?
Yep.
And usually the people will send it over to me because they just don't want to get in the middle of something that's going to be really complex. They'd rather, and that's cool.
Yeah.
Because actually, if you're not used to it, it's not a moneymaker. If you're
No.
not used to doing that and your practice isn't set up for it. If
And
you're
it's
used to it, it can be fun and exciting to do and you can make money at it. But if you're running, like if I was running my old family practice,
mm,
2 chairs and running back and forth and stuff, that was a bad day to have to
yeah.
slow down that much. So
Yeah. Those are such great points. And I really appreciate you taking the time to think. I could talk to you all day about this, just thinking and brainstorming these ideas. And actually, if you don't mind, I might steal part of that from you. I'm lecturing at Winds of Change in January in St.
cool.
Louis, and it's on a lot about what you were saying about understanding the signs and symptoms of pediatric sleep disorder breathing and going into the literature on why it's important to breathe through our nose and be nasal breathers, et cetera. One thing I didn't have planned, which if you don't mind, I'm going to incorporate is taking that next step of talking about how to. I talk about helping the orthodontic community and even the general dental community refer to the medical community. But I haven't explored yet, and I'm going to, of taking the dental community and getting them to figure out how to refer to the orthodontist to set this up a little better to help the orthodontist out. So I appreciate
Yeah.
you mentioning that because I hadn't even thought of that until you said it. And you were saying, I'm like, oh my gosh, like I'm going to incorporate that
Cool.
into
Awesome.
the lecture for it because
I look
that's such a
forward to hearing it someday.
yeah,
That'd be
for
awesome.
sure. So, well, I can't say how much I appreciate it. Just, I want to commend you for fighting this fight. It's not easy. People here, you're again, been in this a while. You've done this, you're resilient, but you've obviously taken a lot of bold steps to do this and fight for the patients and then not only do it, but be willing to go out and teach it and talk about it and be this passionate about it after doing it. So our profession appreciates that and owes you a debt of gratitude for your willingness to not only do this and push the envelope but share it. And so thank you for that because
Thanks, Mike. I appreciate it. This
yeah, I
is,
mean,
I know you're doing a hell of a job. And back in the day when this all started, it was, I did it. My main focus was about my son because I saw it in him and I missed it in him. And I would always ask people, who's your Jake? Because Jake is my son.
mm-hmm,
And all I would want is every lecture for one person to find someone in their life that they could go home and change that kid or that adult's life
yep,
because they heard me. And um, and the neat part now is to watch the evolution of people like yourself going out and all the people you're touching and making changes, especially getting to the core, which is the new residents. Because if you can get to them, then there's not just one Jake that comes with them. There are thousands of Jakes that come with them. So that's awesome. So thank you for all you're doing as well.
I appreciate that very much. That's why I'm so passionate about it. I often said it was a big leap for me to go all in on this, but I always knew I could impact more people with my voice and teaching than I could with my two hands. And as much as I really enjoyed that, You're right. And the residents are so receptive. And once people hear this and understand it, it's just so much fun. And watching them change is great. So thank you for that. And really all you've done. And the time you gave us today, I mean, just really appreciate it.
It's been fun.
Such an awesome conversation.
So thanks.
Thank you so much. Great. Appreciate it. Dr. Jeff Rouse. Thank you. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.